topic for this session is physical examination in gynecology and obstetrics. I'm Dr. Olushola Fasuba. Physical examination almost always follows history taking because both history taking and physical examination should be able to give a diagnosis in about 85 to 90% of cases. And only about 10 to 15% of cases should need ancillary investigation to resolve the diagnosis. At the end of this lecture, you must be able to conduct a thorough general physical examination in obstetrics and gynecology. Then you must be able to have a good idea of how to conduct an abdominal examination in a pregnant woman and a non-pregnant gynecologic patient. Also, you must be able to perform a good pelvic examination in a very good environment. And lastly, you must be able to appreciate the different positions that are necessary to examine these women, both in gynecology and obstetrics. There are 4 ingredients to ensure a very good physical examination. 1, the environment must be conducive. The environment must be conducive. The patient's privacy and her dignity must be maintained. Then we need a good chaperone, preferably a woman, to assist in the examination of these patients. And our presence will make the woman to relax. And there is a need for us to have drapes and gowns that the patient can wear to avoid embarrassment. These 4 ingredients are essential in performing a good general physical examination. As a matter of fact, you start with a general physical examination, in which case you observe the patient from head to toe. You want to look at if this woman is very sick or ill-looking. You can easily detect that by looking at the appearance of the woman. How is she well dressed? Or is she malnourished? And the evidence of malnourishment can easily be obtained by observing the angles of the mouth for evidence of angular stomatitis. Again, you can look at the scaling, the skin. A poorly nourished woman may have a very scaly skin. And sometimes there may be obvious pallor, even from the palm, before looking at the conjunctiva. And you need to observe whether this woman is tall or whether it's short. Just by mere looking at her, whether it's obese or thin or an average size. Then let's look at this woman. Does she look anxious? Does she look depressed? Or does she look agitated? So you need to look at this. And this will determine whether she has any emotional upset. And from your history taking initially, it's possible for you to know whether she's hiding some information from you that may distract you, or that will hide some information as to help in making a diagnosis. It's very essential to take this general physical examination. Sometimes you may have to look at the extremities to see whether there are peripheral edema of the face, edema of the dependent areas in the leg, which you can see, before you can confirm when you begin to palpate. So this initial general physical examination may corroborate your eventual diagnosis. So after this initial general physical examination, then there may be a need to take the vital signs of the pulse rate, of the blood pressure, yes, and if possible, the respiratory rate. And in some cases, you may do the respiratory rate or the raised, if there is a raised jugular vein pressure, you may be able to do that. After these vital signs, then you look at the conjunctiva for evidence of pallor, anemia, or look at the buccal mucosa or the surface of the tongue to see if there is great pallor, or evidence of cyanosis and evidence of good oral hygiene and dehydration. This dehydration could easily be noticed with the dryness of the tongue. After looking at the appearance from the conjunctiva, from the buccal mucosa, and from the tongue, and you may want to look at the anterior abdominal wall, anterior surface of the neck to see if there is any enlargement. An enlargement in the areas of the neck may either be a thyroid gland enlargement or some evidence of thyroglossal. And thereafter, you can proceed to palpate the neck for any evidence of thyroid enlargement, and at the same time seize the opportunity to palpate for lymph nodes enlargement in the submandibular area, and then go down to the subclavicular area and look for evidence of lymph node enlargement. After the subclavicular, the supraclavicular area, then you can now go to the axillary lymph nodes and palpate if the axillary lymph nodes are enlarged. And this is very important, particularly in a woman that is incubating a carcinoma of the breast. Usually, spreads goes to the axillary lymph nodes and the supraclavicular lymph nodes. So it's very important to identify those areas and palpate for lymph nodes. But in gynecology, you may have to palpate the femoral lymph nodes to see if there is any enlargement that may probably arise from carcinoma of the cervix or carcinoma of the endometrium. And we go ahead, before we go to the abdomen, we need to examine the chest, examine the respiratory tract, listen to breath sounds, and percuss, and if there is any evidence of pulmonary lesions, like pneumonia, for instance. Then auscultate for heart sounds and listen to breath sounds. And it's also important that we examine for the breast, we examine the breast for symmetry, for position of the nipples, and probably press the areola to see if there is some milky discharge called gallatoria, and look at the presence of lumps in the breast. After we have done the examination of the chest, we now come down to the abdomen. The examination of the abdomen goes in 4 stages: inspection, palpation, percussion, and auscultation, in that order. Inspection, palpation, percussion, and auscultation, in that order. At the inspection, you must look at the abdomen. Is this abdomen distended, or is it full, or is it very flat? A full abdomen or an abdominal distension may connote there is a pathology, Either there is a mass or a tumor in the abdomen, or in a woman that is pregnant, a pregnant uterus will become obviously distended. And is this abdomen moving with respiration or not? Because in a normal, healthy woman, this abdomen must move with respiration. But if perhaps a woman has an acute abdomen, like acute appendicitis or a ruptured ovarian cyst, in which case this woman is going to shock, or following surgery, there could be a paralytic ileus that will make the abdomen to be silent. So it is very important to ensure to note the movement of the abdomen, so I'll be able to diagnose the pathology in the abdomen based on the history that we have taken. A fullness in the midline may indicate a uterine or ovarian tumor, may indicate a uterine pathology. For instance, a very huge fibroid may make the abdomen to protrude in the central area, whereas fluid collection at the flanks will indicate there is some degree of ascites. And apart from all this, we might also note the appearance of the skin of the abdomen. Is there a prominent linea nigra that is midline, or evidence of striae albicantis, white striae albicantis, or if there are some degree of pigmentations on the skin, or previous scars, either a midline scar or an appendectomy scar, or a transverse scar from previous cesarean section. Right, so all this must be noted at the time of inspection. And it's also important to look at evidence of abnormal vascularity in the anterior abdomen, particularly in cases of anastomosis of the femoral branch of the inferior epigastric artery, trying to anastomose with the superior epigastric artery. In conditions like liver pathologies, liver cirrhosis, liver cirrhosis can sometimes cohabit with a normal pregnant uterus, and you can see this abnormal vasculature, which must be noted. In a pregnant woman, you must be able to see if there is evidence of fetal movement on the abdomen. And before you leave that inspection, ask the patient to cough to see if there are some hernia, if evidence of hernia exists, or the rectal muscles could be dilated, could be separated in conditions of rectal diastasis. So this is very important. So we do this one step by step. The first is to look, inspect, see whether the abdomen is moving with respiration, and then look at what happens on the surface of the skin in terms of color, presence of rashes and pigmentations, presence of scars, or even tattoo marks can be detected. And then lastly, see if there is any hernia or a separation of the rectal muscles from previous pregnancies. Then, after inspection, we go to abdominal palpation. After inspection, we go to abdominal palpation. And in palpating the abdomen, it's very important that you ask the patient to see if there is any area of discomfort or pain. So if there is any area of discomfort or pain, that will be the last area that you palpate. And the first thing in palpation is to do a superficial abdominal palpation. A superficial abdominal palpation, looking for tenderness and tenseness of the anterior abdominal wall. And the superficial abdominal examination must be done in the 9 segments of the anterior abdominal wall. Must be done in the 9 segments of the anterior abdominal wall, looking for evidence of tenderness and tenseness, and occasionally to see if there is a mass or a tumor that can be palpated at the superficial level. And as you are palpating this abdomen, you are looking at the face of your patient. After this, you now go to a deep palpation. Deep palpation. This deep palpation is to enable you arrive at a diagnosis, arrive at the presence of a mass or a tumor. And it's very important that one palpates for enlargement of the liver, enlargement of the spleen, and enlargement of the kidneys. The liver is on the right upper quadrant, and sometimes it could go to the epigastrum with the enlargement. So if the liver is enlarged, try to estimate the size of the enlargement, the consistency of the liver, and show if there is any form of tenderness. And then the spleen is on the left side, just beneath the costal space. And for you to identify splenic enlargement, it's always important to come from the right region of the abdomen and palpate upwards to the splenic area, because the spleen enlarges downwards and inferiorly. It enlarges downwards and inferiorly. So you can easily, it's possible, if you start from the lower quadrant, the right lower quadrant of the abdomen, and go to the left upper quadrant of the abdomen. And then at the same time, you can now palpate for the enlargement of the kidneys by looking, detecting the palatability of the kidneys. After you have done these 3, trying to look for enlargement of the spleen, the liver, and the kidney, then you can now concentrate on the pelvic, which is the major focus in gynecology. Try and see if there is any mass in the pelvis. If you find a mass in the pelvis, it's important to determine the size of the pelvis, the size of the mass, and then the mobility of the mass, the consistency of the mass, and then if you can go below the mass or not. If you can go below the mass, it's unlikely to be a pelvic mass. If you can go below the mass, it's unlikely to be a pelvic mass. Most likely might be an ovarian mass or a mass arising from the bowel. Then, after doing that, is the mass tender? Is it tender? Is it cystic or hard? So all these things, all these consistencies must be noted at the time of examination. And sometimes for you to get the cooperation of the woman, you must be talking to the woman to make her relax so that her mind will be diverted away from her problems. In such a way, the woman will be relaxed and you can easily concentrate more to be able to detect if there is any lesion in the abdomen. I've talked about the size of the mass, the position, the shape, and then the mobility and the consistency. If a mass is found at the sides, particularly in any of the iliac fossa, it's more likely to be an ovarian mass or a mass that is arising from the fallopian tubes or an appendiceal mass. Tumors generally could be cystic or solid. Could be cystic or solid. With a cystic tumor, it may be tense or flaccid. And it's very large. You can demonstrate for either this, if the mass is very large, it may contain some fluid that one can actually confirm using fluid tree or shifting dullness. At the end of the abdominal palpation, then we can percuss for organ enlargement or tumor or ascites. You can percuss, starting from the anterior abdominal wall, using your left middle finger and the left anterior finger, palpating from the central region down to the lateral sides on both sides. Do that. Then, if it's dull at the flanks, then the woman shifts. If the dullness shifts, that's what we call shifting dullness. Shifting dullness. And you can ask an assistant to damp the anterior abdominal wall and then put one hand by the flanks and tap with the other hands. So this is what we call the fluid tray. So if you tap on this side, you feel the movement of the fluid against the palm of the left hand. Or otherwise, you tap on the left, the movement of the fluid is felt at the palm of the right hand. So this is what we call the fluid tray. So a fluid tray, presence of a fluid tray or a shifting dullness will detect the presence of ascites in the abdomen. And this is why percussion is very important, particularly in patients with enlarged ovary. And finally, we do auscultation. Auscultation just involves using the stethoscope to listen to the presence of bowel sounds at the Mark-Burney point. The Mark-Burney point is that point 1/3 from the anterior superior iliac spine, 1/3 from the anterior superior spine, or 2/3 from that point from the umbilicus through an imaginary line that is drawn from the umbilicus down to the anterior superior iliac spine. So that 1/3 region, so the anterior superior iliac spine, corresponds with the Mark-Burney point, and that is where you can have the maximum bowel sounds at auscultation. And as I said earlier on, if there is no bowel sounds, think of a ruptured viscous like appendix, or think of paralytic ileus, particularly if this woman has just had surgery in the last 24 to 72 hours. So maybe a cause for a silent abdomen. In a pregnant woman, it's possible to obtain a fetal heart sound after 20 weeks using the normal fetal stethoscope or a peanut after 20 weeks. Yes, after examining the abdomen, then we now come to pelvic examination. This pelvic examination is the most challenging aspect of gynecological examination. It's most feared by women because of pain and because of some of them feeling shy or because of exposing their private parts. This type of examination may be omitted in virgins or in young adolescents. Maybe omitted in virgins and adolescents. But before it is conducted, as I said earlier, a good environment is necessary. You need to allay the fears of the woman, and then there must be a chaperone. To avoid you being embarrassed or embarrassing the patients. And again, usually you need a warm instrument to be able to do this examination. Warm. If the instruments you are using or hands are cold, it may cause some form of reflex in this patient. So avoid using a very cold hand and avoid very cold instruments. And the two hands must be gloved. Must be gloved. So it's very important. For you to have a successful pelvic examination, all these conditions must be maintained. The procedure of vaginal examination entails 4 stages. It entails four stages. One is inspection of the vulva or the external genitalia. Second is also trying to inspect the cervix and the inner part of the vagina. And thirdly, to digitally examine the vagina and the cervix. And lastly, to look to do a bimanual pelvic examination using both hands to detect if there is a tumor or a mass in the pelvis. As I said, it has 4 stages. One is inspection of the vulva or the external genitalia, inspection of the cervix and the vagina, palpation, digital palpation of the cervix and the vagina, and then a bimanual palpation of the pelvic organs. But occasionally, the third stage may be done before the second stage. That is, a digital examination of the pelvis, of the pelvis may be done before inspection of the cervix and the vagina. And this is done usually where you suspect carcinoma of the cervix, like the woman presents with bleeding following intercourse, or complains that there is narrowing of the vagina following insertion of herbal medicines or local medicines, that you think there is gynaecology. You may have to do a digital examination before a speculum examination. To VVF for vesicovaginal fistula, for instance, carcinoma of the cervix, gynaecology. So that order, the third stage will come before the second stage. So as not to cause injury to the woman. Again, in doing this pelvic examination, there are certain positions that we allow the woman to maintain. You can do it in 4 positions. The first position is called a lateral position. A lateral position. This position that we are looking, the woman easily turns to her left side and brings up the 2 legs, right? And if you look at this, it's a very comfortable position for the woman. It can easily be assumed and does not expose unduly the patient. It does not expose unduly the patient. And it can permit a thorough examination, a reasonably thorough examination. This lateral position is good, and most women are very comfortable with this lateral position. The second position that we always assume, ask women to assume, is what we call a semi-prone or Sims position. As we are looking with this diagram, the woman is lying on her left side, and the left hand is brought behind her and probably dangling on the side of the table. The left leg is straightened while the right upper leg is flexed at the ankle. Again, this is a very good position that has been used in the examination of vesicovaginal fistula and probably uterovaginal prolapse. It gives a good view of the external genitalia, just like the lateral position that we discussed first. This is a better position than a lateral position. The semi-prone of Sims position is a better position than the lateral position. The third position is what we call a dorsal position. The third position is what we call a dorsal position. In the dorsal position, the woman lies on her back. The woman lies on her back, and then the lower legs is flexed at the nail and the thigh abducted. The legs are flexed at the nail and the thigh abducted. This, again, it affords a very good view of the vulva, but does not permit easy introduction of a speculum. It does not permit easy introduction of a speculum. It is a convenient position for a bimanual palpation and is more frequently used in the gynecological clinic. You can see the physician is introducing the right hand into the vagina while the left hand is trying to press down the abdomen to see if the two hands, if the left hand and the vaginal hand can meet. If they can meet, that shows there is no mass there. But if there is a gap between them, obviously, there is a mass, either there is an enlarged uterus or there is an enlarged ovary or any other organ. And the last position that we use is what we call lithotomy position. And look at this diagram. The woman's buttocks are brought to the edge of the table. They are brought to the head of the table and the legs are supported on stirrups. But this is not a very convenient woman. This is not a convenient position for a woman that is not under anesthesia. They tend to feel embarrassed. But if you are going to do procedures like dilatation and curettage, examination under anesthesia, this is the best position for us to use. So these are the four positions that we commonly use in the examination in obstetrics and gynecology. The examination of the pelvis, the steps in examining the pelvis. 1, you empty the bladder. You either ask the patient to go and empty her bladder shortly before the examination, or you use a metal catheter, use it to introduce it to the urethra and then empty the bladder. But the problem with this metal catheter, it can easily introduce infection. So it's always better for the woman by herself to go and urinate. And second step is inspection of the external genitalia for the presence of a vaginal discharge, for signs of infection, for evidence of ulcers in the vulva, or new growths in the vulva or swelling, and signs of genital mutilation, if the clitoris has been cut or not. Thereafter, you separate the labia and inspect the urethral orifice for urethral discharge, and then go down and look at the 5 and 7 o'clock of the vagina and look at the Bartholin's dots to see what's happening to the orifice. And thereafter, while still separating the labia, you ask the woman to cough or to strain to see whether the cervix will prolapse out of the vagina, or if there is going to be any stress incontinence. So these are the steps these are the things you do when you do inspection of the external genitalia. Yes, we want to inspect the vagina and cervix. And you use these two important instruments, the coscos or bivalve speculum on the left side, and the seam speculum on the right. So it's very important that you be able to distinguish between these two equipments, the seam speculum and then the bivalve speculum. So when you pass these instruments, if you are going to use a lateral position or the seam position, you use the seam speculum. And what do you take note after inserting the seam speculum or the coscos speculum? You look for evidence of vaginal discharge. If the vaginal discharge is thick, white and mucoid, it shows that you may be dealing with candidiasis or Candida albicans. If the discharge is purulent and offensive, you are dealing with Trichomonas vaginalis or bacterial vaginosis. If it is blood-stained, if that discharge is blood-stained, you might be dealing with a malignant ulcer or a cancer of the cervix, for instance. All this vaginal discharge was subjected to microscopy, caution, and sensitivity to be able to make an actual diagnosis, whether it's a fungal infection, it's a bacterial infection, or it's a malignant infection. And step 4 is a digital examination. And as I said earlier, this digital examination may be performed occasionally before the speculum examination, where you suspect malignancy or you suspect narrowing of the vagina from previous injury or from obstetric labor and so forth. So in this digital examination, the right index finger is, after putting on a glove, you introduce the right index finger. After patting the labia, introduce the right index finger gently and palpate the walls of the vagina. Then, when you palpate it, as you are doing that, you are looking at the patient so that you do not elicit undue tenderness. And then you can again palpate the fornices, the 2 lateral fornices, to see if there is any growth or any bulging from any tumor from above the abdomen. You do the lateral fornices, and then do the anterior fornix, and then the posterior fornix. And thereafter, you try and touch the cervix. When you touch the cervix, in what direction is the cervix pointing to? Is it anterior? Is it posterior? And this will help you to know if there is any evidence of anteversion or retroversion. A normal cervix points downwards, so it's an anteverted, it points downwards. But sometimes when the uterus is badly situated, you can see the cervix pointing upwards, and we say it is a retroverted cervix, right? So you need to do all this, carefully for you to be able to know what is happening. A cervix of a nulliparous woman that has not given birth to a baby is always closed and thin. It's thin and closed. But a woman who has had 1 or more deliveries, the cervix is large and is open. So it's possible that your index finger can enter that cervix and stick. But in labor, in pregnant woman, you can easily identify the cervix. The cervix somewhere is about soft or probably red, pink. It's pink. A pink uterus, a pink cervix is a normal cervix. And again, there are some abnormalities of the cervix that you can pick at speculum examination, particularly cervical erosion, in which case the mucosal lining of the columnar epithelium is trying to cover the external horse. You can see that it appears velvety. You can see it appears pink and velvety. Cervical erosion. Or there could be evidence of cervical laceration from previous instrumentation or from previous delivery. Yeah? And there could be some growths also on the cervix, which can be detected at that time. And evidence of ulcers on the cervix, hyperemia, can also be detected, or a polypus growth. And this brings, after the digital examination, we now do the bimanual examination that we do at dorsal position. In this, on a gloved hand, you first of all introduce the middle finger. Look at the middle finger of the right hand, and then carefully insert the right index finger gently into the vagina, and then gently twist the 2 fingers, and with your left hand in the suprapubic region, you can easily examine the anterior fornix, the posterior fornix, the lateral fornices, and then try to see if there is a mass in the pelvis. And finally, before you remove your hands from the vagina, try and move the cervix left and right move the cervix left and right to see if there is what we call cervical excitation tenderness. When there is cervical excitation tenderness, it shows there's some degree of infection and can be seen in acute pelvic inflammatory disease or in cases of endometriosis. So this cervical excitation tenderness will be there. And if by chance a mass is felt when you are doing this bimanual examination, look at the position of the mass, look at the size of the mass, determine the mobility of the mass, and then the consistency. Is it cystic or it's hard? So it's very important that all this picture is known. Yes, finally, all the examinations we have done so far, they are done in respect of a non-gynecologic, a non-pregnant woman. But all these examinations too are also true for pregnant women from the general physical examination down to that pelvic examination. But in pregnancy, these pictures are put here. The pictures here shows how we typically examine the abdomen of a pregnant woman. How do you do it? But this particular topic, this examination, will be further demonstrated when we take the topic of antenatal care. The first step is to determine the height of fundus. See the first diagram? The physician is putting the hand at the uppermost part of the uterus. Uppermost part of the uterus to determine the height of fundus. And this height of fundus must correlate with the gestational age in weeks. This height of fundus must correlate with gestational age in weeks. And again, we tend to use the tape measure in centimeters to measure the height of fundus, the fundal height, right? From the uppermost part of the fundus down to the pubic symphysis. And that's what the first diagram is showing. After that, you now come down to examine for what is presenting in the lower uterine pole. Two things can be presenting in the lower uterine pole. It's either the head of the fetus or the breech of the fetus can present at the uterine pole. So this examination is very, very important. It's very, very important because we want to see what is in the lower uterine pole. And the head of this baby is presenting. You can see the two hands of the physicians there. And the third Fasuba is to again go back to see what is in the upper pole. And again, the fourth something is showing how to prepare for the lateral part of the uterus, the lateral sides. See what is where the back is, where the limbs are. And finally, it palpates whether the head of the baby has descended into the pelvis. You can see 4 fingers placed along the symphysis pubis, trying to measure the level of distance, what we call the Christian's law of fifth. Is it 4/5? Is it 2/5 of the heads? But this is better demonstrated at the antenatal care and during clinic, which you will definitely see. And finally, there may be a need to do a rectal examination or a combined rectovaginal examination, as the case may be. And this will be very relevant in cases of carcinoma of the cervix and cases of carcinoma of the cervix and again carcinoma of the vagina and so forth. In conclusion, a detailed history taking and a meticulous physical examination should be able to assist the gynecologist in making a diagnosis in about 85% of cases, and only about 10 to 15% of cases that ancillary investigation is necessary. I thank you for listening.